but it's impossible to ignore the potential of the platform technology. And if we think about what the RNS system brings, well, first of all, there's a huge safety data set and evidence, demonstration of really impressive efficacy. We are able, as we've shown you, to monitor brain electrical activity, and we can do so anywhere in the brain, and therefore, theoretically, for any type of brain disorder. The device lends itself to targeted and personalized therapy. And of course, there is this really exciting and very fast discovery in the area of biomarkers. And then, of course, you don't want to wait until a patient is sick to treat them. We want to treat them before they have the symptoms of their disease. I mentioned that it's impossible to ignore, and it's impossible to ignore because we are participating in collaboration, sometimes as co-investigators, sometimes in a more distant role, for externally funded studies in disorders other than epilepsy. And they fall within two main categories. So I'm going to group them into neuropsychiatric disorders. And you'll see the list of, again, this is externally funded research, mostly NIH, in depression, impulse control, loss of control eating, and PTSD. And the other category falls in the area of memory and cognition, so restoring function. These are also NIH funded. Many of them have to do with memory in the domains of navigational memory, also cognitive assessment, understanding brain plasticity, understanding memory, and also there is a trial in autism disorder. So all of this is happening, bringing things to us and us able to support them with our enthusiasm, often our data science and our device. But there are opportunities for providing responsive stimulation. And now I'm going to introduce Dr. Sheth again to share how he views this.
Yeah, great. Thanks very much. So just in the way of framing, I'm going to talk about sort of two, framework level organizations in terms of the types of disorders outside of epilepsy that we might think of as being opportunities to use RNS. I'll spend a little bit of time on this first one and a bit more time on the second one. So the first one really are those with, actually, are these out of order? Can I just check, see what the rest of what the next one is? Yeah.
I think this is the one you want to talk first, no?
It's the paroxysmal one first. Let's, keep going. Is there another one after?
No.
No. Okay, fine. Well, then I'll say the first one briefly, and then kind of get to, let's go back one more. One more. There we go. Okay. All right. So what isn't on the slide there, but just, there's really nothing to show graphically, but again, in terms of framework, I mean, there are disorders, let's go forward one, that are paroxysmal. And what I mean by that is that they have specific episodes of when the symptoms manifest, and then the rest of the time, the patient or the person, is fairly normal. I mean, think epilepsy. They're not perfectly normal when they're not having a seizure, of course, but the whole philosophy, of RNS, which is really borne out quite well, is that when the brain is not having a problem, when the brain is in a more or less normal, non-pathological state, leave it alone. So that's worked very well for epilepsy, as you've seen. Other disorders, outside of epilepsy that have that same paroxysmal nature are, for example, Tourette syndrome or PTSD or addictions. Stay back. I'll ask for the advance. Sorry. So those are paroxysmal disorders, that might have a similar kind of biomarker, a neural biomarker, like we see in epilepsy, that we could use to trigger stimulation. I'll spend the rest of the time talking about what's on this slide and going forward, which is a different type of disorder, which is not paroxysmal, but rather it's slowly evolving. So these are disorders that have pathology that doesn't just occur in fits and starts, but rather is there most of the time and maybe evolves in terms of severity. In terms of the de-risking of using a responsive neurostimulation type of system for those, that process has begun, but there's a lot of work to be done still. The philosophy here is different. It's not leave the brain alone and stimulate only when you're going to have a symptom outburst, but rather the symptoms are always present or often present and just slowly varying. And so here the philosophy is more that the stimulation output adjusts to neural biomarkers that we can measure. And as shown here, just in the parentheses, a lot of times these biomarkers can evolve slowly. So over days, weeks, months, not moments. But like what we're used to in epilepsy, the idea that we need to individualize our identification of those neural biomarkers to the individual patient, is still very applicable. Examples here are depression, memory disorders, and other psychiatric disorders like OCD and anxiety disorders. These, I think, goes without saying, these are not ones that that come and go. It's not like, with depression, sometimes you're acutely depressed and other times you're totally fine, but rather that, they vary slowly over time, and hence kind of the motivation for this. Next slide, please. So I'll spend just 5 minutes focusing on this idea of depression. We've done a lot of work in this field. And again, the idea is to measure, to see if we can even identify neural biomarkers of mood states and then use them for adjustment of stimulation. This is work that's funded on this NIH grant, also from the Brain Initiative, like the one that Marty showed you a minute ago from about LGS. This is one that we got a few years ago for depression. Next, please. So the idea is this, we're very used to doing intracranial monitoring in patients with epilepsy. We've been doing this for decades. It used to be with grids put on the surface of the brain. Now for 10, 15 years, it's really mostly with stereo EEG, meaning thin, small electrodes that are placed into the individual. And this is done, at the stage when we have some idea of where seizures are coming from, but not well enough to come up with a definitive plan. So these electrodes are placed, the patient is kept in the hospital for a week or two, for example. We allow them to have seizures, and then once they do, now we can tell exactly where they came from. And then we may see, are they a candidate for a resection or neuromodulation like RNS, et cetera. So this is, tried and true paradigm in epilepsy, but used very seldom outside of epilepsy. So this study is one that we're borrowing this approach from epilepsy of temporary intracranial neural recording and using it to understand the varying mood and affect and cognition in depression. So we're taking here 10 patients with severe treatment-resistant depression. So these are not patients with epilepsy who might be depressed. Rather, these are people who have typically never had a seizure, but have severe depression. And we're implanting them with these temporary monitoring electrodes spanning these regions that are shown here, kind of across frontal and temporal areas that are relevant for mood management. And we keep them in the hospital in the epilepsy monitoring unit for 10 days. And we study their individual neural signatures, of mood, affect, cognition, et cetera. And then after they leave the EMU, we adjust neuromodulation, based on that kind of bespoke, tailored neural signature pattern that we have identified. Next, please. So on the right here, are just 3 papers that we've published just in the last couple of years. I'm not going to bore you with all the details, but I want to highlight a few salient points. So the first one is on that top figure on the top right. The point of this was that we really do have a pretty good developing understanding of what neural signatures and where they come from indicate or predict different mood states. What we did in this study was we took, in this case, 3 of these patients, and we asked them periodically, 5 or 6 or 7 times throughout the day, how are you feeling? A quick mood questionnaire. Took a couple of minutes to administer. And so we kind of have, over the course of, 10 days, maybe 40 or 50 snippets of time where we have an estimate of their mood severity, their depression severity. And at each of those times, we also have the neural recordings in all those brain regions, shown on the left. And so then what we could say, when someone is feeling a little less depressed, they're not, of course, normal or cured, but, when their mood is in a little bit better state, what does the neural activity look like? And then, in contrast, when they're in a worse state, more depression. What does the neural signature look like at that point? And then we can do the analyses and say what particular neural features in what brain regions predict, better versus worse mood state. And that's what's shown here, where with the red and the blue. And so the kind of summary, from this study is that you can see if you just kind of zoom out or, kind of cross your eyes that, across these three patients, there's definitely some consistencies. You've got the kind of the red on the top in those neural features and the blue are on the bottom. So there's some generalization that, all three of these patients, and we've done this for now, a total of 6, do show, some consistencies in pattern. But then you can tell if you zoom in, of course, that, there are some individual differences. So now if we just direct our attention to the bottom right, this is a very recent study that just came out a few months ago where instead of, so we want to do the same thing. What are the neural signatures associated with more versus less depression? But here, instead of labeling them with, a survey, how are you feeling now? How are you feeling now? How are you feeling now? Doing it that way is a bit fatiguing. It's a bit subjective. And so instead what we did, if you kind of see in that green box, that conversation box, you can see a snippet of what this person said. We basically just use conversational data. So this individual was very talkative, and so we would talk to them, about their history of depression and just history of life. And we would use AI to really extract the emotional content from the conversation. So it's kind of a much more objective way of assessing how someone is feeling just based on what they're saying. And by doing that, bottom line is we got a very similar sort of pattern of activity, indicating that we can really do a lot of this assessment of mood state, not with surveys that are cumbersome and slow and subjective, but through just the objective extraction of emotion from what someone is saying. Okay, so now just to kind of summarize, the points here, if you could go to the next animation, please. Yeah. So these 3 bullet points are kind of what I'd like you to take home from this discussion. One is important just in terms of practicality. The information that we need to decode, in this case, depression severity or mood, is available using clinical macro electrodes, meaning the electrodes that we see on typical neuromodulation devices like the RNS device. So that's good to know, that we can decode that information from, the clinical devices. The second one is that these biomarkers do have some general features. It's not that each person is completely different than every other one. That would be pretty hard to, imagine a feasible study. So the generalization, again, from the top right, the red on the top, blue on the bottom, is there for, everybody that we've studied so far. That speaks to feasibility. But, there is some need for individualization because in detail, there are differences. And we're used to this, with the RNS device of individualizing that detection ability. And then finally, that bottom bullet point is that neural biomarkers are certainly very interesting. Alongside that, we should, I think, really study these behavioral biomarkers as well. They are an exciting and rich source of information. And they provide objective evaluation of how someone is doing, especially with mood disorders, let's say, in a way that clinical measures can't, in terms of temporal frequency. We can't assess someone's depression many times throughout the day. There's just not validated scales for doing that, nor is it practical. But through behavioral markers, for example, what someone is saying, or from smart devices that people are very happy to wear. In fact, they pay for these smart rings and watches and phones and whatnot. The amount of behavioral information we can get from those is staggering in terms of the size of someone's social network, how mobile they are, how much they interact with others versus they're stuck at home because they're sick. So that behavioral data is very rich, and I think coupled with the neural data will be very exciting. Next, please. So I think really the next step in terms of what we would love to do, following this study, which will be done in the next year or two, would be to take this information and employ it on a larger scale with a device like the RNS device that can actually record neural data. That's a big limitation we have in our current trial, is that the system we're using doesn't record any neural data. So if we could actually record data outside of the hospital setting when people are just out living their lives, again, pair that with behavior in terms of sociability, mobility, et cetera, the hypothesis would be that if we adjust the stimulation output of that device based on that neural and behavioral input and feedback, that we'd be able to, in the case of depression, for example, keep people, in a less depressed state more often for longer with less chance of relapse. And then one more click, please. And so really, the additional adjunct that would come out of this is the ability to remotely monitor. This is something that we're really lacking, just in the field of neurological and psychiatric care. What the RNS system is allowing us to do for epilepsy, is kind of leading the edge with that. But imagine now applying that to many other disorders that we just don't have the ability to routinely monitor how someone's doing. Okay, next slide, please. This is my last slide. It's going to be kind of a summary and a little bit of expansion. Just 4 thoughts. Next, please. The first is that, again, to recapitulate, the ability to continuously monitor neural biomarkers of the target state, I think, is going to change how we address many disorders beyond epilepsy, neurologic, and especially psychiatric. And those include disorders of mood or memory. Next. And then, of course, as we're measuring these biomarkers, we adjust our output based on those in order to match the supply of stimulation to the demand, meaning, what the patient is feeling. And these, again, could be in a paroxysmal way for disorders that have fits and starts of symptom severity, or slowly evolving ones like I talked about at some length in terms of depression. Next. This point I mentioned on the previous slide, remote monitoring, I just want to highlight it for a second because this is something that we're really missing. Again, as I said there, with many neuropsychiatric disorders, we just don't have objective biomarkers. All we can do is ask someone, how do you feel? And there's standard scales, that are good for communicating that information, but they're not good for measuring it, in a dense way or in a feasibly deployable way to people just outliving their lives. And so the idea in that bottom one, is to move beyond, symptom-based therapy, right? So not just kind of, symptoms that require cumbersome assessments or clumsy ones, but rather to objective and biomarker-based therapies, again, neural or behavioral. And then final thought is engagement of patients. Again, people are very happy and will themselves pay for the ability to engage, with their own health, right? My step count, my readiness potential for my smart ring, whatever that means, right? So we're very obsessed, as a culture about knowing how we are doing and being told about that. Now imagine being able to do that, in a clinically meaningful way in terms of you're more likely to have a seizure in the next couple of days. So, perhaps be aware of that. Or, you're perhaps, entering a period of time where you're more susceptible to having a relapse, of depression. So, perhaps the stimulation is going to adjust, but also wouldn't it be good for you to know that, to be able to anticipate what's coming? So anyway, those are just my thoughts, about kind of responsive neurostimulation beyond epilepsy. I'm happy to discuss if there's time now or later.